Yeah.
Okay, sir.
We're good to start, sir.
Okay. Yeah, good evening, everyone. Welcome to our master class from the Department of Critical Care Medicine, Yashoda Hospitals. Every Tuesday, we are conducting these sessions since almost 3.5 years, and these sessions are well received across. And the mastermind behind that is our Venkat Raman sir, is also there. So for today's topic of discussion, the most common thing that is day in, day out, we see in ICUs, especially the ICUs which are is the patients being referred from rural areas, and even in rural areas, the patients coming to ICUs. That is snake bite environment. It's a global concern. But when I was looking at the statistics, around 50,000 deaths occur in India itself because of the rural predominant population, and especially during rainy season. That's what going on right now. So to discuss this important topic, we have two expert panelists with us. Dr. Rajib Paul sir, he is the HOD Internal Medicine and Senior Consultant Critical Care at Apollo Hospitals, Jubilee, Hyderabad. So we welcome you, sir.
Yeah, thank you.
Yes, sir. And
Thank you
we
for
have the senior expert panelist, Dr. Maneendra. He's the HOD and Senior Consultant of Critical Care Medicine at Gleneagles Hospital, so from Hyderabad. So welcome you, Dr. Maneendra.
Thank you, Kaladhar. Thank you, Venkat for the opportunity.
Yeah. So we have two students with us from the Yashoda Hospitals, Secunderabad, DrNB students. So Dr. Vinay and Dr. Vyshnavi, they present this case. So while we go through, anytime you can interrupt and ask questions, sir. Dr. Rajib Paul sir and Dr. Maneendra.
Yeah.
So Dr. Vinay and Dr. Vyshnavi, good to go. And start sharing your presentation and go forward.
Okay, sir. Good evening, sir. Today we are going to present a case on snake bite. A female of 55 years had a eligible history of snake bite on 29 June at 7 a.m. in a field, Munipalli, Nizamabad district. Followed by she had complaining of pain in the left foot and ankle region associated with swelling on the dorsum of left foot extending up to ankle, and followed by 2 episodes of vomitings and 2 episodes of loose stools. She was initially taken to outside hospital where she received 10 vials of ASV followed by 5 more vials of ASV. From there she was referred to our center due to coagulation abnormalities. At that time, no bleeding manifestations were present. Primary assessment, coming to the our hospital, airway and C-spine was patent, breathing was adequate, circulation where blood pressure was 110/70 mmHg, disability was not present, exposure, on exposure left foot swelling was present up to knee joint, warmth was present, redness was present, tenderness was present, fang mark was not seen, and peripheral pulses were present. Systemic examination, central nervous system, GCS, E4, V5, M6, and moving all 4 limbs, and no defects were present. Respiratory system, bilateral air entry was present. No added sounds were there. Cardiovascular system, S1, first heart sound and second heart sound were heard. In ER, receiving vitals were, temperature was febrile, pulse rate was 97 per minute, blood pressure was 110/70 mmHg, respiratory rate was around 18 per minute, saturation was 94 on room air, GCS was 15/50, and GRBS at the time of presentation was 150 mg per deciliter. Abdomen was soft and non-tender. Limbs and vascular system, all peripheral pulses were present. In ER, whole blood clotting time was done, and it was more than 20 minutes. It was clot, and clotting time was 4 minutes and bleeding time was 2 minutes. Patient received 5 vials of ASV in 5% dextrose in 500 ml over 5 hours. In ER, they transfused 4 FFPs. They have given injection paracetamol, 1 gram IV stat, and injection piptas 4.5 gram IV stat was given in the ER, and started on IV fluids 100 ml per hour, and patient was shifted to AMCU. It was diagnosed as snake bite with hematotoxicity with AKA with cellulitis, query of viper envenomation.
So
Do you want to
Yeah.
interrupt
Yes,
here and
please.
ask any questions?
So
Rajib
from
sir?
the like all the questions, sir, in exams where they actually give us presentation, Rajiv sir and Maneendra, you can actually start with the initial presentation so that I think they will get exposure to that exam.
Yeah, Venkat. I get it. Just don't worry. I'll take over. Am I audible?
Yes,
Yes,
sir.
sir.
So, I mean,
So-
if you go back to the initial slide, I mean, the presentation of this patient was after how much time to your hospital?
After 1 day, sir.
After 1 day. So presently, you're diagnosed a case of snake envenomation, which is most possibly a vascular toxic snake bite.
Yes, sir.
So, other than WBCT, what are the other signs you are looking for in this patient?
Coagulation abnormalities, sir.
Hmm.
Outside she had done where whole blood clotting time was around 86, more than 20 minutes. It was around 86 minutes. And INR was around 10, sir.
Hmm. So there was swelling in the leg, but as you said, the pulses were present.
Yes, sir.
But was there evidence of any other cellulitis or any sort of necrotizing fasciitis in the involved leg?
Gradually, after 1 day, she developed cellulitis, sir.
Hmm.
But no necrosis or no further bleeding manifestations at the local site, sir.
Hmm. So there was so for you it was a spreading cellulitis.
Yes, sir.
So do you think the antibiotic choice is okay in this patient?
Actually, we have after giving the in the ER piperacillin and tazobactam, we have started clindamycin in AIMS in our ICU,
Nice.
sir.
Okay. Why did you choose clindamycin?
For mainly anaerobic coverage.
Why do you want to give anaerobic coverage to this patient?
Because in a snake bite, after a bite of the snake, its
Clotting time.
its venom contains gram-negative and anaerobic organisms.
Very good. So the antibiotic choice, as per the present, looks quite good from your side. We present tazobactam with clindamycin. So what is the protocol of anti-snake venom administration in such vascular toxic snake bites? As I can see, as per your presentation, you received already 10 vials outside, followed by 4 or 5, 15 vials outside. And then you gave 5 more vials after coming to your hospital.
Yes, sir.
So how do you decide the requirement of ASV in such patients?
Initially, when patient presents to us, we have to check for local manifestations of any bleeding tendencies were present or not. Apart from that, we have to do PT, INR, APTT every 6th hourly, sir. If at whole blood clotting time, if whole blood clotting time is more than 20 minutes and a dearrangement of coagulation abnormalities, we will start ASV of starting with 10 vials, sir. And every 6th hourly, we will repeat PT, INR and APTT, sir.
So what is the protocol for WBCT? How frequently will you be doing it for the patient?
Initially, every 6th hourly we will do, sir.
That's too long. That is pretty because already your patient has come with coagulopathy. Your WBCT is quite high in your hospital. So already you designed WBCT whole blood clotting time. So what is the protocol of the Indian guidelines which about WBCT?
4 to 6th hourly, sir. If severe bleeding manifestations are present, we can repeat 1 to 2nd hour.
No, you can't do that like that. You should have a protocol. The protocol basically every 30 minutes for the first 2 to 3 hours and then subsequently every hourly. When the WBC counts at WBCT become normal or better, you can do it hourly. But first 2 to 3 hours, it will be every 30 minutes. That's the present protocol of whole blood clotting time. And when do you give FFP to this patient? What are the indications of giving FFP to this patient?
INR was more than 10 at the time. Outside, she
INR was more than 10,
10,
sir.
sir.
If any INR of more than 5 with bleeding manifestation, we can give FFPs.
INR more than 5 with bleeding tendencies.
Yes, sir. with bleeding.
Maneendra, you have any questions?
No, what is 20-minute whole blood clotting time?
We have to take a venous sample, sir, directly from the
Okay.
patient in a plain glass test tube. We have to keep it aside.
Okay.
Ml of blood is taken, sir. We have to keep aside for 20
Mhm.
minutes without any shaking.
Without any interruption.
Then after 20 minutes, we have to tilt the glass tube and we have to see whether there is a clot formed or not, sir.
Okay.
If no
Then
clotting is present, we will consider as a whole blood clotting time more than 20 minutes, and patient is having developing coagulation, venom induced coagulation, and we will start giving ASV, sir.
okay. Then when you are doing 20-minute whole blood clotting time, what is the rationale in doing PTINR also? So should you do both of them, or doing, if 20-minute whole blood clotting time is not in the as per you, if 20-minute whole blood clotting time is abnormal, so still should you do PTINR, or it is not needed?
It is needed,
It is needed, sir. For any to check for any coagulation factor deficiency, for any hypofibrinogen, anything, we have to check for fibrinogen and other coagulation, PTINR, APTT.
Absolutely. So even if the 20-minute whole blood clotting time is normal, you have to check the PT, APT, TINR, and we have to correct that also. So in the same patient, if like what Rajib sir was asking, if the patient, the 20-minute whole blood clotting time was normal, and if coagulopathy was not there, is there any other justification for ASV?
We have to wait and watch for the symptoms to appear.
Any local envenomation is there, sir? We can give.
We can give.
Mhm. The question is, if the patient has evidence of coagulopathy, no evidence of coagulopathy, do we give ASV? That is the direct question. What we are asking.
No, sir.
No.
No, sir. Without any coagulation abnormality, with a whole blood clotting time of less than 20 minutes, we can hold it, sir.
As you have given the history diagnosis,
Okay,
the patient
I'll put the
also.
question.
Yeah, go ahead. Sorry.
Yeah, no problem, sir. No, I'll put the question more straightforward to you. What are all the indications for ASV in snake bite?
We are having a hematotoxic indication, sir, where whole blood clotting time is more than 20 minutes. INR is more than 2. Thrombocytopenia of with platelet count of less than 1 lakh.
PT was more than 4 to 5 seconds of lab value, lab control value, sir. And neurological abnormalities like ptosis, ophthalmoplegia, and paralysis, diaphragmatic paralysis, any respiratory paralysis was there, sir. In any cardiotoxic like hypotension, dysarrhythmias, ECG changes, we will consider antivenom, sir. And another renal abnormalities like AKA, decrease in oliguria or anuria, and rhabdomyolysis or myoglobinuria, we can give it, sir.
Any local swelling, if at all spreading
more than half of involved limb.
So yeah, that's what I was asking. So cellulitis itself, any local inflammation itself is a sign for indication for ASV. The pain, like sir, which here you told cellulitis, you told vomiting, you told abdominal pain. So those are all also are indications for ASV.
Okay.
So in the next slide,
why do you think WBCT is chosen by the guidelines and not PT, PTT, PTO, and PTT in the guidelines as the important modality?
Because it is easily available, sir. In regular PHCs also we can do with only glass bottles are available. We can do it, sir, without any further need of missionaries or anything.
Yeah, that's why there is a part of the guidelines, and because it is easily available and anyone can do the test anywhere. So that because most of the snake bites would happen in the rural areas where the tertiary facilities for doing a PT, PTT may not be always there. So go ahead with the other slides. One more question I had to ask before you go ahead. Is there any upper limit of snake ASV in this patient? Now that we have diagnosed as an AKI and also having also this patient, does he have evidence of rhabdomyolysis?
CPK was around only, no sir, no rhabdomyolysis.
No rhabdomyolysis. Then what is the cause of AKI in this patient?
Because of systemic envenomation causing kidney injury.
The venom causing
Venom
AKI.
induced AKI, sir.
AKI, sir.
Like acute tubular necrosis, like.
Okay. Go ahead.
These were the lab values when a patient presented. Hemoglobin was 13.7. These were the on 30th June. These were the investigations which were outside lab investigations. Sir. HP was 1 second. Sir. HB was 13.7 gram per deciliter. TLC was around 20,800. Platelet count was 1,76,000. PT was around 136 and INR was 10.2, sir. And APTT was 176, sir. These values she was presented to ER, sir. In ER, we repeated the profile where hemoglobin was 13.1. Total count was 23,730. Platelet count was 1,59,000. PT was 21.9 and INR was 1.6 seconds. This was after giving 4 FFPs and 10 cryos which were given in the ER. Followed by blood urea and blood urea nitrogen was 58.27. Serum creatine was 2.5. Sodium potassium chloride was 141, 5 and triple 1. Fibrinogen was 75. Bleeding time was 2 seconds. Clotting time 2 minutes. Clotting time was 4 minutes. After coming to the ICU on the morning, first 30th. After coming to the ICU, we repeated again the values. Hemoglobin was 10.5. TLC was 13,500. Platelet count was 1,26,000. PT was 16.8 and INR was 1.2. Then on this 1st July, hemoglobin was 10.2. TLC was 12,666. Platelet count was 1,25,000. PT was 18.1 and INR was 1.2. Blood urea was 95. Creatine was 5.3. Sodium potassium chloride were 141 and 4.4 and 109 respectively. Then again after 6th hourly, we repeated the PT, INR and APTT. Here, the PT was 17.9 and INR was 1.28. APTT was around 80.3. So here we have given another 5 vials of ASV, sir. And on 2nd, she had a hemoglobin of 9.3, TLC of 11,040, platelet count of 1,20,000, PT of 17.5 and INR of 1.26, and APTT came to 26.2, and serum creatine was 1.9.
So total, how many vials of ASB you have given?
Outside she received 15, sir. In ER 5 vials, and after rise of APTT, we have given another 5 vials of ASV, sir. Total 25.
25 vials. Okay. So do you have any upper limit of giving ASV in such patients?
Usually in a Viper toxicity, we give up to 30 vials, sir.
Usually, neurotoxic, yes.
20
Neurotoxic,
vials.
it's about 20 vials.
So, okay, I mean, mostly it is averages around 15-20 vials. Well, as a common averages, except in a life-threatening envenomation with vascular toxic bites where the limb injury is worsening or coagulopathy is persisting, you can go 25 to 30 vials.
Okay.
But mostly averaging around 15-20 vials is what is the limits for neurotoxic or vascular toxic. Go ahead.
These were the outside lab values, sir.
Yeah.
She received 15 vials of ASV outside. Whole blood clotting time was done in after coming to our ICU, sir. 3 times we had a value of more than 20 minutes, sir. These were the serial ABGs which were done. Initially on 30th, she was having compensated metabolic acidosis, sir. Other than that, her ABG values are also normal, sir.
So any role of giving bicarbonate in this patient?
If at all she is presented in acute kidney injury with decreased urine output and any metabolic acidosis, if at all present, we can we can give bicarbonate, sir.
Sorry, please. So what is the rationale for giving soda bicarbonate in a patient with metabolic acidosis in your ICU?
pH less than 7.1, sir.
Okay. So
Then
if the pH is 7.2, you don't need to give soda bicarbonate.
we have.
So do you look at pH or do you look at anything else? See, the answer for this question is pretty difficult, but whenever I have a patient with metabolic acidosis, I look at the sodium. If the sodium of the patient is 150, I will not dare to give more soda bicarbonate. I look at the way he is breathing. If he's really tachypnic and washing out CO2, even with a pH of 7.3, probably I'll try to give some soda bicarb. If the patient is pretty comfortable, if it is a CKD patient who is breathing comfortably, probably I'll wait on the soda bicarb.
Okay.
So, and if the same patient with a pH of 7.3 has some kind of hemodynamic instability, which is not being explained with anything else, then probably I'll look for soda bicarb and see.
Okay.
There's a question from the audience. What is the repeat dose of ASV? Is it 5 vials or 10 vials? What is your answer on that? This is one common question which has come up.
Actually, if it is a neurotoxic envenomation, we will initially start with 10 vials of ASV, sir. Over 1 hour, we will check.
Repeat doses.
We will check for a improvement of the neurological signs. If they are present, we won't repeat another vial, sir. Another ASV. If at all no improvement is there, we will repeat another 10 vials of ASV, sir, after 1 hour. If it is a viper toxicity, then we will initially start with 10 vials of ASV, sir. Every 6th hourly, we will check for PTINR and APTT. If at all there is any abnormality, we will 6 vials of ASV, sir.
For every 6th hour, 6 vials of ASV.
So if it is a 10 kg old child, 10 kg is a child versus a 70 kg old, aged 70 kg person, what is the difference in the ASV dose?
Same dose of ASV, both will receive, sir.
Why?
Because
the amount of venom entered into the body is equal in pediatric and adult population, sir.
Good.
Why is the dose different for different snakes?
Depend on how much amount of anti-snake venom will neutralize the amount of the snake venom, sir.
So what does this ASV contain?
Is a immunoglobulin, sir. Is a peptin refined FAV2 fragments of IgG immunoglobulin, sir.
Okay, so it acts against one snake, it acts against one variant, it acts against 2 variants. So how does it act? Against which type of snakes does it act?
Pardon me, sir.
What are the snakes that are covered? What are the snakes that will be covered, or the envenomation which snakes would be covered with your ASV?
It will cover crates, sir.
It will cover the
Brussels viper, saw scale viper, crate cobra, sir. It won't cover myotoxic snakes and pit
hump-nosed
pit viper, sir.
Absolutely.
So there is a question also from the audience. Why is the difference in the doses between a neurotoxic versus vasculotoxic snake bite. As you said, neurotoxic requires little lower doses than the vasculotoxic. Any reason for the difference?
Improvement of neurotoxic symptoms are fast recovery compared to vascular toxics.
Why? They are less potent venoms.
No, sir.
No, sir.
Then why will the neurotoxic ones recover faster? Vasculotoxics will recover slower. The answer is very simple. Neurotoxic venomation. Basically, what you do with the ASV, you neutralize the free venom.
Yes, sir.
The neurotoxic, when this is already established diaphragmatic paralysis or respiratory muscle paralysis, most of the venom is bound to the nervous tissue.
Nervous tissue.
So there's very less amount of free venom to be neutralized. So repeatedly giving the ASV is just a waste of money and more chances of developing autoantibodies or antibodies to the ASV. So there's no point in giving because the venom is already attached to the nervous tissue.
Okay, sir.
But the same is not for a vasculotoxic where there is a tissue injury.
Tissue.
In tissue injury, the venom can keep on being released intermittently into the circulation because the venom basically hydrolyzes the muscle tissue. And with hydrolysis of muscle tissue, the venom can be intermittently secreted into the bloodstream. And that can cause the coagulopathy that you are seeing. So that's why the higher doses will be required for vasculotoxic, while neurotoxic with lower doses are required. Okay?
Okay, sir.
There's another question from the audience. Sorry, Maneendra. You can go ahead.
Yeah, go ahead, sir. Go ahead, sir. No problem.
Yeah. The audience had a question of role of antifibrinolytics. I don't know what to answer for this, but what do you think as audience, as student, role of antifibrinolytics in this patient?
There is no role
No
in
role of,
snake envenomation, sir, in antifibrinolytic.
Why?
Mhm.
Do you have a role? I mean, don't have a role? Or you say small role. What is a small role?
No, sir, no role.
No role.
No role you told. I heard
No,
small
sir.
role.
No role.
Okay, correct. That's the thing. I'm sorry, I had small role.
Okay, sir.
So no role of antifibrinolytics in this patient. And another question from the audience is the role of atropine and neostigmine.
Yes, sir.
Not this patient, but another other patient.
Yes, sir. In a if at all we have given 10 vials of ASV and we have seen for the improvement of symptoms, in such conditions, we can give atropine and neostigmine, sir. If we have given a atropine dose of 0.6 mg and a neostigmine dose of 1.5 mg, sir, then we will see for 30 minutes and we will repeat 5 doses, sir. For 5 doses, sir. If at all at the third or fourth dose, we will check whether there is an improvement in the ptosis or persisting symptoms. If at all there is an improvement, we will consider as cobra bite, sir.
No,
Then-
Vyshnavi, you're meaning to say neostigmine atropine, you use it a diagnostic tool to diagnose it as a cobra bite versus a
cobra bite
vascular.
versus the crate.
Great, sir.
So you are basically using it as a diagnostic tool.
Right.
So any role of atropine neostigmine in the treatment plan?
If it is a undiagnosed bite and if at all the patient is having without any local fang marks or any envenomation is minimal envenomation is present and patient is having respiratory distress, in such conditions we will ventilate the patient and we will give ASV along with we can give atropine and neostigmine to confirm, sir.
Maneendra, are you happy with the answer?
You want to give atropine and neostigmine both?
Yes, sir.
Yes, sir.
Initial atropine followed by
Neostigmine,
neostigmine, sir.
sir. Atropine.
So how will you know whether it is you look at the recovery of the muscle power?
Yes, sir. We will see for ptosis, sir. Any improvement of more than 50% of the ptosis present
Ptosis.
initially, it's a positive test.
So why atropine is needed? Neostigmine alone is not sufficient.
Actually, neostigmine is an anticholinesterase, sir. When we have given the neostigmine, it will bind the anticholinesterase enzyme and it will increase the acetylcholine, sir. Because of increased acetylcholine, which is having a parasympathetic action, it will cause hypotension and bradycardia, sir. So to compensate this, we will give atropine, sir.
Yeah,
So for
to mask the
Yeah.
muscarinic effect.
So for I think all the anesthetists who are listening, we all use reversal.
Yes, sir.
So myopyrrolate. So that is the reason it contains It contains a combination of neostigmine and glycopyrrolate.
Glycopyrrolate.
So here we use atropine because atropine has a better penetration into the CSF also.
Dr. Vinay, basically, you have to be a little clear on the concept of using atropine neostigmine, especially in snake bite conditions. Remember, intubation always remains the priority in such patients.
Okay, sir.
It is basically, I mean, you are giving ASV and you are just seeing whether the patient recovers of the ASV. So if you are using your neostigmine atropine, you have to be very meticulously monitoring the patient. So your treatment of your neurotoxic envenomation basically is early intubation whenever there is any evidence of respiratory muscle weakness. You can buy some time with neostigmine atropine, but this is not the protocol of treatment for any envenomation of neurotoxicity. I mean, if you're not able to intubate the patient or you are transferring from a rural center where intubation facilities are limited, there probably. But in a tertiary care center, you could use it as a diagnostic tool, as you told, or basically for some time, if you are feeling there's a very mild envenomation and you are giving the ASV, probably patient may not require intubation. But any evidence of persisting neuro weakness, you do not continue the multiple doses, like 5 doses that you talked of. You need to intubate the patient early. Yes, because the whole idea is here is a bound toxin, and bound toxin will take its own time to release. So you cannot rely on neostigmine atropine as a continuation to maintain the patient in that time. Another question which has come from the audience is single breath count. How do you use single breath count in deciding when to intubate such patients?
Usually, we will assess the patient on single breath count, sir. We will ask the patient to take a deep inspiration and count the numbers. Usually, if a normal person who is not having any respiratory failure, he can able to count up to 40 numbers, sir. 1 to 40 numbers. If he's having a respiratory failure, tachypnea, in such conditions, he can't able to count 40 numbers, sir. It is a bedside tool to assess the respiratory failure analysis.
Respiratory insufficiency.
What number are you? Sorry.
Which are all the conditions where you use this test now, apart from snake bite?
We can use in a COPD patient, sir.
Okay. Okay, anything else?
Pulmonary, as a bedside pulmonary function test, we can.
Any poisoning else you can use it? Any poisoning which you can?
OP poisoning.
Yes, OP poisoning you can use it.
Yes.
Neuromuscular disorders?
Yes, you can use that also.
Myasthenia
Myasthenia you can use.
Myasthenia gravis we can use, sir.
GB syndrome, myasthenia gravis.
Another question which has come from is can there be both neurotoxic and vasculotoxic symptoms in the same patient?
Yes, sir. In Russell Viper bites, there will be both neurotoxic and hemotoxic symptoms will be there, sir.
Okay, good.
So can you just elaborate what are the most common types of snake bites and what are the systems which are affected?
Sir, in most of the Russell Vipers Russell Vipers involve me mostly hematotoxic, sir. In most common in South Indian and Sri Lankan territory, there will be neurotoxic also, sir, like ophthalmoplegia, facial paralysis, and diplopia is also there, sir. In cobra bites, it will be mostly initially local envenomation with neuroparalysis is there, sir. In crate, it's a minimal local envenomation with the paralysis is there, sir.
Okay.
In sea snakes, we will have musculotoxic features.
Fair enough.
What is the role of tourniquet in such patients in your treatment protocol? Because patients will be initially taken care of by somebody else.
We should not apply tourniquet in such patients, sir.
Suppose somebody comes with tourniquet from outside, you don't have a control on that. So what do you do when the patient comes with a vasculotoxic snake bite and tourniquet tied on suppose on the thigh and the foot and the bite is in the foot?
We have to give first, before opening the tourniquet, we have to assess for
Sir, before we we have to remove the distal tourniquet first, sir. We have to hold for the proximal tourniquet. After initiation of ASV
Yes,
only, we will remove that proximal tourniquet.
tourniquet. Sir.
So usually,
So,
what, how should you transport a patient, or what should you do when you find a patient with snake bite? What is the first aid?
First aid was initially reassurance, sir. First, followed by involved limb immobilization, sir. Pressure immobilization is better than only with any pressure immobilization with splint is better than normal immobilization.
Sir. Then we have to accompany with the person affected should be accompanied with 1 or 2 persons, sir, to take care. We have to also ask them regarding any development of new signs or symptoms regarding this while transporting the patient to here.
Okay. So can snake bite cause immediate death? Can snake bites cause immediate death?
No, sir.
No.
So usually, if it is a vasovagal, see, even more than that is the reason reassurance is the word which is given most importance. Even you told the first word which you told is reassurance.
Yes.
So if the patient goes into a panicky situation, you can find a vasovagal shock, and you can see patients having a cardiac arrest also. And if at all the venom directly injects, the fangs directly go into the blood vessel, and if there is a venom envenomation directly into a venous system, then probably you can see sudden death.
Okay, sir.
A very good response has come from the one audience. This is a concept which actually we don't practice, but it is in the guidelines. That when you're removing tourniquets, if you can put a BP pressure cuff proximal to the tourniquet, you should put it to a suprasystolic level, then remove the tourniquet and gradually reduce the BP cuff, the BP cuff pressure. That is one way of reducing the systemic envenomation. This is in the guidelines, but we don't practice it regularly. But this is one way of reducing the envenomation. Can you go ahead? I think your presentation is still left. I think you can go ahead.
Lab parameters on 30th June, sir, on ER. Abnormality was there in fibrinogen, where it was a 75, and she was received 10 cryoprecipitate, sir. Then after that day, on first patient developed oxygen support. After receiving 4 FFPs and 10 cryoprecipitates and IV fluids, we have taken a chest X-ray where it shows a bilateral infiltrates and perihilar haziness was present, sir. We thought of fluid overload.
What is this called? What is this situation called, where you have given transfusions and after that patient?
This is a transfusion related acute lung injury or transfusion associated circulatory overload, sir.
Acute lung injury term is still there. Berlin's definition has removed acute lung injury, right?
Okay.
So this is now usually we call it as transfusion associated circulatory overload.
Circulatory.
Okay.
On first, hemoglobin was 10.2, sir. TLC 12,660. Platelet count of 1,25,000, sir. PT of 18.1 and INR of 1.29. Blood urea and blood urea nitrogen of 95 and 44.3. Creatinine of 5.3. Sodium potassium fluoride were 141, 4.4 and 109. After 6 hours, PT was 17.9 and INR of 1.28 and APTT was around 80.3, sir. Ultrasound abdomen showed grade 1 fatty liver changes, edematous gallbladder wall thickening, mild bulky kidneys with a mildly raised cortical echo texture. Today echo was done and EF was 62%, no regional wall motion abnormality and normal LV contractility was there. Patient was advised with repeat of PTINR and APTT 6 hours. As APTT was increased to 80 seconds, we have given another 5 vials of ASV. Patient had a left lower limb cellulitis, and we have started on injection clindamycin 600 mg IV TID along with piperacillin and tazobactam, which was ongoing. Nephrology review was given in view of worsening AKA and advised of SLED for 12 hours with ultrafiltrate of 3 liters with heparin nil and access via right jugular sheath.
So 1 second. So again here, why is it 6th hourly that you are repeating PTINR APTT? I think that was answered before or not.
For why?
For
Patient, why PTINR APTT is being repeated 6th hourly? Sir already told that first 1-2 hours, what should be the way you have to test? Sir, Rajib sir already told. Here, I think after 24 to 24 hours on day 3, I think. So you are doing every 6th hourly. What is the rationale for that?
it will take around for liver to compensate the coagulation factors. Liver will compensate within 3 to 9 hours, sir. The coagulation factors, sir.
Okay. Next.
On second, hemoglobin was 9.3, TLC of 11,040, platelet count of 1,20,000, PT of 17.5, INR of 1.26, and APTT of 29, sir. Serum creatinine came to 1.9. 6th hourly PT INR APTT was repeated. Repeat value of PT was 15.9 and INR was 1.4. Patient was still requiring go-to support, and chest X-ray was showing pulmonary edema picture. Patient advised limb elevation on this day and had a local swelling persistent, but no tenderness was seen. No tenderness was present. Nephrology team at this time advised scuff with ultrafiltrate of 3 liters and heparin free and access a right jugular sheath for 6 hours, sir.
What is scuff?
Slow continuous ultrafiltration, sir. Where we will remove only the fluid.
Without any dialysate.
Okay. So what are the indications for dialysis for this the SLED that you did for this patient?
For this patient, worsening AKA was present, sir. Serum creatinine was increased up to 5 point.
So is serum creatinine indication for initiating SLED?
No, sir.
No, sir.
In this patient, there is a associated pulmonary edema is there.
was there, sir.
That's why we
One of you answer, yeah.
with worsening of AKA with increase of pulmonary edema picture will be there. So fluid overload status will be there. That's why we initiated SLED for 12 hours.
Okay. Could a diuretic have helped in this patient? Diuretic challenge?
Sir, and mostly in transfusion associated lung injury, there is no role of diuretics.
But you are talking about you did dialysis not for TRALI.
Yes.
You did for basically for a transfusion into circulatory overload. For that you did the ultrafiltration. Now you are secondarily following up with a scuff also. So basically your target is to remove of fluid from the lungs. Dialysis or your SLED or HD, whatever you do, is not going to help your if there is any element of ARDS, it's not going to help anyway. So is there a difference between giving a diuretic versus doing an ultrafiltration or a SLED in this patient on the initial stage?
If at all, initially within 24 hours, we can give a diuretic challenge, sir, of furosemide 40 mg, where we can give forced alkaline diuresis to the patient.
We don't need alkaline diuresis, we just need a diuresis.
Okay.
The diuretic challenge still could be given to this patient. If the patient is oliguric despite diuretic challenge, then you could take this patient off for an ultrafiltration or a SLED.
Okay.
So this is basically if you're considering transfusion-induced cardiac overload or circulatory overload, that's the protocol. I mean, you could still give a diuretic challenge before taking off for a invasive procedure.
I think DICAT was already in, sir. Probably they have already done one session on the before day.
Yeah. That's they already done the first day itself. That's what. Now you advised limb elevation for the patient. What is the reason for it?
There is a worsening of limb swelling was there, sir.
So what is the idea of doing limb elevation?
To decrease the hub price.
To decrease the local edema.
Uh,
Okay. So you said patient had metabolic acidosis initially.
compensated. sir.
Compensated metabolic.
Compensated. Okay, so okay, now nephrology. Now can go to next slide. Okay.
On
I will
third-
answer one I'll answer one question from the audience because audience has asked one question of acidosis on ABG. Sled might have been initiated for that. Is it correct? Somebody had asked acidosis was there on ABG, so sled might have been initiated for that. Then
At
volume
that
alone. Is it
time,
correct?
No, sir.
no,
No, sir. It is
It is-
compensated well. As we
So the
didn't-
acidosis was not the indication for, so that is very clear to the audience. The acidosis was not the indication for initiating because it was quite compensated. So we did not start sled for the acidosis part of it. Was there hyperkalemia in this patient? No.
no, sir.
No, sir.
So what are the indications of hemodialysis or sled in any patient in the ICU?
Fluid overload state, sir.
Hmm.
Uncompensated metabolic acidosis, sir.
Hyperkalemia.
Hyperkalemia.
Uremic encephalopathy.
Uremic encephalopathy or uremic
sir.
pericarditis.
Okay, go ahead.
Failure, medical management, Lasix challenge, if at all, Lasix challenge failed.
Refractory pulmonary edema.
Refractory pulmonary edema.
Hmm. Okay. Uremic pericarditis, uremic encephalopathy,
And
refractory pulmonary edema, severe metabolic acidosis,
Drug overdose.
drug overdoses.
Mm.
So on third, now go ahead.
On 3rd July, oxygen was tapered, sir. Advised incentive spirometry. Local swelling was subsided and no tenderness was present. Chest X-ray showed bilateral haziness, suggestive of still fluid overload status. Advised of repeat PTINR APTT 12th hourly. If any abnormality was present, patient was advised to give ASV again. Patient was planned to shift to step down, sir. On 5th, she was discharged from our hospital, sir, with a persisting AKA, which was non-oliguric.
Okay.
At that time, the creatinine was around 2.43, sir.
So if the family asks what is the status of dialysis, will it be long term? Should the DICAT be retained? How will you tell the family?
We will say if at all there is a further worsening of any limb swelling or any urine output, if at all decreased, or any bleeding manifestations, if at all present, we will ask them to come again for a visit, sir.
See, they are asking what should they have come and asked you. So should I get an fistula done to my patient because he has been initiated on dialysis? So what will you suggest them?
No, sir.
No, sir.
So this is an acute kidney injury,
Kidney
probably. So that you have to explain them, no? So you have to clearly tell them that this is an acute kidney injury because of this snake venom. Probably few more sessions of dialysis may be needed or may not be
May
needed
not be
based on the
needed.
clinic.
Any further questions, sir?
Audience questions, some questions I don't think, but we should answer. Okay. Role of calcium in neurotoxic snake bite.
Yes, sir.
Yes, sir. In crate, there is presynaptic damage of the neuromuscular junction will be there, sir. In that cases, we have to give calcium gluconate because calcium acts as a neurotransmitter in presynaptic vesicles.
Is it part of the guidelines?
Yes, sir.
Yes, sir.
And how much dose we have to give?
10 ml of 10%
10%.
calcium gluconate over 10 to 50 minutes, sir.
How do you decide how many doses to give?
We will give first dose and we will wait, sir.
But you're also giving ASV, no? Along with that.
Yes, sir.
Yes, sir.
So do we need to repeat calcium subsequently, or we'll just give one dose?
We will give one dose.
Okay. I'm not sure of the guideline, which, but I'll just check it. It's a strong recommendation. I'm not sure of it.
Yeah, it is there in Indian snakebite guidelines.
2025.
Guidelines is there.
Yeah, it's there. But yeah, most of the times because it's a presynaptic, the calcium once it opens, when we give calcium as calcium channels open, there is a possibility that acetylcholine, which is there in the vacuoles, it will be exocytosed and more acetylcholine will be available. That is the concept. But most of the times, as you said initially, once the venom is fixed in the presynaptic terminals, most of the time they get the axon get damaged. So the new sprouting of the axons, if they happen, then only the recovery happens. So calcium may not help much, but there are like guidelines there.
One of the audience, what is the ideal muscle relaxant for intubation?
Like a non-depolarizing neuromuscular blocker, vecuronium or rocuronium, sir.
What are depolarizing and non-depolarizing muscle relaxants?
Depolarizing muscle relaxant is succinylcholine, sir. If at all we are thinking of any if at all there is any muscle involvement, there will be hyperkalemia, sir, because of potassium release. If at all we have given succinylcholine in such individuals, it will further exaggerate the hyperkalemia, sir. So we will go for non-depolarizing neuromuscular blockers like vecuronium and rocuronium.
Good. We'll be worried about hyperkalemia because cellular injury will be there because of the tissue injury.
Yes, sir.
Yes.
Monovalent versus polyvalent ASV, which is better?
Polyvalent.
If any snake is identified, we can go for monovalent, sir. But monovalent vaccines are not available in India. Only polyvalent vaccines are available in India, sir.
Absolute availability is a huge issue. So polyvalent, and we have already told which are all the snakes which will be covered.
Another problem which we should discuss is basically a patient who develops allergy and a patient who develops anaphylaxis to ASV.
Yes.
How will you manage both patients? One who just has an allergic reaction, another person who develops anaphylaxis and shock.
In anaphylaxis and shock, we will first stop the ASV which is going, sir. We will assess airway breathing circulation. If at all required, we will intubate, sir. Then followed by IV adrenaline 1 mg stat given, sir. And we can give chlorpheniramine maleate, sir, 10 mg.
Is it IV adrenaline or intramuscular?
Actually, 0.5 mg intramuscular adrenaline.
Yeah, the IV adrenaline only in the cardiac arrest situation.
Arrest,
Okay.
They
0.5
develop
mg.
those in tachyarrhythmia, yeah, ventricular tachyarrhythmia.
But the problem is the patient who needs anti-snake venom. What do you do?
We will slowly start the anti-snake venom after 10 to 15 minutes, sir.
After stabilization of the patient, we will again
start.
restart the ASV, sir, if clear indication of ASV is there.
So that's an important message that even if the patient has an anaphylaxis, we are still supposed to administer ASV under proper monitoring at a very slow rate after 15 minutes to half an hour. We should restart the ASV and try to see as much ASV can be given to the patient. So ASV has to be administered despite a first episode of anaphylaxis.
Okay.
Yes.
There are guidelines, they say, sir, like giving 0.25 mg adrenaline subcutaneous before starting ASV to prevent allergic reactions. What is your take on that, sir?
I mean, prophylactic doses, you mean?
Yes, sir.
Yeah, I said prophylactic, subcutaneous, especially they specify to give as a subcutaneous that 2.25 mg, almost 1/4 of the dose what generally we use for anaphylaxis once the patient develops.
I mean, there's no protocol. I don't think any protocol exists from the people maybe practicing that. But I mean, don't think that should be routine part of the treatment, because many times in the snake venomation, patients are so agitated, many times tachycardia. Actually, that dose also may initiate a state of ventricular tachycardia and cause complications for us. So prophylactically, we will not go for, unless the patient has a significant history of allergy in the past, then we may think. Otherwise, routinely, I don't think this has exists any role of giving a 0.25 cc adrenaline subcutaneously.
Yes, sir. And the difference between lyophilized versus liquid form of ASV. So that is, of course, by default, most of the times it's the government Serum Institute of India and all they produce.
Yeah.
So may not have much of choice, but there are some reports where liquid form may have less anaphylaxis as compared to lyophilized, where
Lyophilized
it's
form.
reconstituted. So, and
But
while
life,
reconstitution, it has to be taken care properly. Aseptic precautions have to be followed. Most of the times that may cause febrile reactions and all. So what
Yeah.
about the snake bite in pregnancies? Like how do you manage?
We have to give the same anti-snake venom dose, sir. 10 vials, sir. And we have to assess fetal heart monitoring regularly, sir.
So what are the implications on the fetal health?
There is a high risk of abortions will be there, sir. Fetal
Yeah,
bradycardia, fetal
abruption,
tachycardia.
especially if they are associated vasculotoxic and hemotoxic,
Mm.
the possibility of placental abruption
Placental abruption.
Placental abruption.
will be more.
Fetal bradycardia.
And the presentation, especially when we look at the crate bites, especially without much bite and the early morning myasthenic syndrome like presentation, we had seen some cases where they sleep on the floor and suddenly present with bulbar palsy-like and respiratory distress, and then they get intubated. So we had seen patients like brain dead mimics also. They presented with people dilated, fixed, and totally E1, M1. So V1, the GCSF3, and even thought of the people thought of going for a brain dead organ donation. That kind of thing when we did MRI brain, which was normal, and finally we could not conclude whether it is this. But the history points towards he slept on the floor and all. What do you think, sir? This type of presentation, how to approach to this type of patients?
Can you repeat the question once again, Kaladhar?
Yeah, the crate bites presenting as brain dead mimics. So totally they're flat, like no.
I
No,
think
if why don't?
Maneendra, yeah.
that's what neostigmine does help you in such situations.
No.
You're talking. Hello.
Yeah. So I think what I think Kaladhar is trying to point out, Rajiv sir and Maneendra, is how actually a crate bite presents. Sometimes they present to the emergency room as an acute abdominal pain, colicky pain with nausea, vomiting, sometimes also with a respiratory failure. So that's what I think he's asking. So the question which actually Dr. Maneendra is trying to put out, trying to give a clue. Suppose you give a neostigmine in those patients who are actually unresponsive, neostigmine with atropine. You have 3 neurotoxic poisons. You're saying ki, cobra can do the same, crate can do the same, some vipers can do the same. Do all the patients will respond as a diagnostic tool by your neostigmine test, or some of them will respond, some of them will not respond?
Vyshnavi.
Sir, only cobra
Only
will
cobra bite.
it will respond to atropine and neostigmine, sir.
Why? Why?
Because it acts post-synaptically. It is a post-synaptic bite, sir. Cobra bite is post-synaptic. So post-synaptic it is because they block the acetylcholine esterase. If at all we given that, it will regenerate the acetylcholine availability, sir.
So it is a post-synaptic receptor blockade mechanism
yes,
to which
sir.
it works. So you will have a response. As actually very importantly, Dr. Rajiv sir pointed out that this can be a diagnostic tool. Relying on that just to treatment will be a challenging. So if needed, these patients need to be supported with ventilation till the patient recovers. And there was another interesting point, I think, which both the examiners were trying to point out, that you have different toxins. One is you said ki neuroparalytic toxin by cobra, and you other side ki hematotoxin, vascular toxin, myotoxin and all. The pattern of giving these drugs or ASV is different for both category. In neuroleptic or the Cobra, you give the first dose when you see the patient with neuroparesis and followed by another couple of hours you examine and give. That's it. After that, there is no role. So it is a gap of 2 hours.
Yes, sir.
Whereas is it different from others?
For vascular toxic, we will wait for 6
6
hours.
hours, sir.
So as Rajiv sir said, initially you may need to repeat every hourly. Then once you find that is more than 20 minutes, you start the dose. Once you give a ASV, it has to be every 6 hourly has been pointed out.
Okay, sir.
So the question is, if it is for the same pattern for a neurotoxin envenomation, why it doesn't help for a crate bite?
Crate bite, it is a presynaptic bite, sir, where it will damage the axon terminals which has been containing the acetylcholine, sir.
It is in presynaptic acetylcholine vesicular toxin mediation. It will not be helped by any kind of acetylcholinesterase drug. By
Yes, sir.
increasing your acetylcholine, it will not help. The neostigmine test will not be helpful. That's what is the answer. Probably sometimes your neostigmine will not be helpful in that. So crate bite patients can be sometimes present to you like the bite may not be painful. The bite may not be known to the maybe the patient, and the marks are insignificant. There will be no local signs. They may present you like an abdominal signs and then respiratory paresis. So I think that's where they were asking, sir, trying to point out whether that can be a presentation. And many of the times they will be going to a hospital saying acute G, pain abdomen, loose stools or some cramp, and then suddenly collapsing respiratory paresis. And when you see the GCS will be E1, VT, M1. And pupils will be mid-dilated sometimes and fixed also, not reacting. Neostigmine test will be negative.
Okay, sir.
You are in a dilemma whether you are dealing with a brain dead patient. So this is one of the brain dead mimics. Where the confirmation is before a brain dead, the prerequisite is you have to have an irreversible brain injury. And to that you do an imaging. And that imaging, if it shows a normal MRI or a normal CT scan, probably that rules out it is not brain dead, it's something else. So then your other all tests come into play and you probably ventilate them. That's it, and wait for more time. Sir, there are more questions, sir, in the EA.
I think at what rate ASV is given, it's an important question. Okay, I think we should answer this also. What is the rate of which ASV is given?
Initial 12 vials, I will give in within 30 minutes, sir. 30 minutes to 60 minutes.
Yeah. So basically, it's the rapidity which is important. When we have to give it rapidly only. Within 30 minutes is the best answer in this condition with 10 vials in 30 minutes, yes.
Then
What
is there any
if the
best,
patient, pardon, yeah.
is there any best fluid to dilute ASV?
We will give in 5% dextrose or
Any reason?
prevents the
I don't remember any protocol like that. It's more
5%
And
dextrose or
dextrose or normal saline, sir.
yeah, both we can use. I don't think there is
sir.
any special predisposition to anything. What if the patient came to hospital after 3 days of snake bite? Is the dose of ASB different or same?
We have to first see whether it is a truly snake bite or
No, we're talking about snake bite only.
then
He has a
we have-
cellulitis. He is your patient only. He has come to you after 3 days. He has a cellulitis. No ASB has been given outside.
then we have to if it is local swelling is persistent like that, and we have to give ASV, sir.
Yes, sir. Same protocol is there.
Yes. So whatever the patient comes in, the later also we'll have the same protocol of 10 vials initial bolus. What we're going to give. Is there any role of desensitization? Yeah, any role of desensitization of ASB?
Yes, sir. If at all the patient is having severe patient may have severe anaphylactic reactions to minimal doses of ASV also, sir, less than 5 ml also. In such conditions, we have to dilute the ASV to 1 in 10,000 units, sir. And we have to slowly start the ASV of 0.1 ml around like that. For 10 to 15 minutes, we have to observe. If at all no allergic reactions were present, and we have to continue for another 0.1 ml has been given, sir. Then we have to see for another 10 to 15 minutes for any development of allergic reactions. If at all not present, we can continue the bottle that we have prepared in 1 in 10,000, sir. Then afterwards, we can continue other bottles of 1 in 1,000, 1 in 100, and 1 in 10 prepared solutions, sir.
When will you call the surgeon in a patient with worsening cellulitis and maybe developing necrotizing fasciitis? When will you call the surgeon to do a surgery, and what are the precautions you will take in this patient?
Usually, we will see for any compartment syndrome developed or not, sir. In such conditions, we will assess for peripheral pulses. Any paralysis or any pain that has been increased in a passive movement also. Any pallor that has been present. In such conditions, we will ask the surgeon to come and visit.
So answer is evidence of compartment syndrome.
Compartment syndrome, sir.
Evidence of compartment syndrome, we will go for a fasciotomy. So any precautions between a normal fasciotomy versus a fasciotomy after snake veneration?
We have to check for coagulation parameters prior posting the case, sir.
Okay, that we will check. Anything, any other difference? So ASB, this is one indication where the ASB can be repeated post surgery, is because post fasciotomy you could have a sudden release of envenomation. So you could give a 5 vials to the ASB after the immediate post surgery. That is one recommendation which is there. So in such cases, you can use an ASB extra doses.
One question from Manimala madam. Is there any drug being developed for snake bite, especially for rural areas?
Sir?
Manimala madam has a question. Is there any drug being developed for snake bite, especially for rural areas? I don't.
Monoclonal antibodies like Crofab, there are some monoclonal antibodies being investigational, I think so, but I could come across in some of the
But we are
articles.
talking about
Crofab
rural
it is
areas.
called,
Madam
but
is talking about rural
easy
areas.
tab like
Kaladhar, it's
Madam
not
has
Yashoda
to
Hospital.
answer. Can we actually activate Madam, if at all he wants to answer? I'm not sure. If not ASV, I think there are some questions where mycotoxin poisons are there, snake bite is there, which is not common in Indian context. I think this is an Australian subcontinent where we see more commonly. But if I don't have an ASB, I will give a supportive care. I'll save the patient by tubing and intubating. No patient with neuroparesis will die if you tube and intubate. It is just a supportive care which can save the patient. So, Madam was asking what is the drug developed? Other than ASB, I think ASB is the only thing which is available everywhere now in the rural primary centers. That's the only thing which probably is there and went out.
one basic question, Vyshnavi. Do we need to give tetanus prophylaxis in these patients?
Yes, sir.
We have to check for the previous tetanus doses, and we have to give booster dose, sir.
Yeah, basically snakes mouth contain tetanus bacilli. The possibility of patient landing up with tetanus also high.
So there are some more questions, sir. Dose of FFP SOR and dose of FFP, where it came, sir?
I don't know. I couldn't understand this question. Dose of FFP SOR means
role of blood products and dose of FFPs.
Probably, if the patient is having coagulopathy, is there any role of FFPs is his question. If at all you want to give, what should be the dose?
You can answer. What is the dose of FFPs you supplement for any coagulopathy? I don't think it is
10
different
to
for
15
snake
ml per
bite.
kg body weight, we will
FFP supplement.
Most of the times it is after giving ASV, because before giving ASV, if they give FFP, it is like adding fuel to the fire, because the possibility that these patients are between DIC and all. So once we give ASV, neutralize the venom, probably the same dose, same dose, like as Venkat sir was telling, most of the times it's 10 to 15 ml.
So, sir, even though it was a part of the same organization, I was just contradicting the use of FFPs in this patient. So, indication of correcting coagulopathy if there is no active bleed. I do understand that the INR was more than 10. What do you think, Rajiv sir and Maneendra? INR more than 10 was a scary number, but correcting them, or first give a ASB and see if the patient is not actively bleeding, keep FFPs ready, or what do we do?
No, INR 10, Venkat, would not need a immediate correction by giving FFP unless the patient has evidence of ongoing bleed. And prophylactic INR treatment probably is not strongly indicated in such conditions.
Okay.
If the patient has a high risk of bleeding, tendency of patient multiple anticoagulants and some acid anticoagulants like azithromycin, and then okay, I would understand such patients. But a routine young guy, the farmer who gets bitten and INR is 10, he has no comorbidities, no medical history. So there is no need to actually treat the INR with FFP such conditions. Evidence of ongoing bleeding anywhere else could be an indication, yes.
Or a procedural immediate threat of a procedural.
Yeah, if you're going for a procedure, that's a procedural indication. Other than that, prophylactic transmission just for correcting INR for the sake of correction probably is not supported by any guidelines right now.
There are questions, sir. Maneendra, what is your take on that?
No, probably with the increasing point of care test, probably we can use a TEG for such situations. And see, we have in this particular patient with coagulopathy, we have corrected cryo. We have corrected with cryo.
Both cryo and FFP, true.
So then, as per the rationale, then cryo should have been avoided. So why when we have corrected in a snake bite per se, probably I'll use a TEG, and if at all my TEG says that the maximum amplitude is increased based on the TEG's values, probably I'll try to correct it.
Okay.
Because this is a patient who is in coagulopathy and who can decompensate.
Okay, I think the answer is if a patient is not actively bleeding, you are not pursuing for a procedure. Correcting the coagulopathy in a known snake envenomation may not be warranted. And after ASV, if you are warranting for a procedure, probably you will need. And coagulopathy is an ideal marker to actually repeat your ASV. If you actually mask that guide, then you have no clue why your INR got corrected and all. But how is it got corrected? You don't know whether it is because of your supplementation or because it is because of your anti-snake venom. You don't know why it is 6th hourly. After supplementing, you said every 6th hourly you will be giving, right, ASVs again, and you're testing and giving. Why 6 hourly? Why not 4 hourly? Why not 2 hourly?
But coagulation factors, the liver produce coagulation factors, at least it will take some 3 to 9 hours time.
Very good. So ideally, once you actually neutralize your anti-snake venom, whatever toxic venom, then you are actually allowing the liver to resynthesize your clotting factors. And it generally takes, as you said, 3 to 9 hours of a mean of 6. So that's where you actually at least expect that by minimum time of that, you will actually resynthesize back your clotting factors and your coagulation profile gets better. So that's why I think so there is one more question. Sir, do you do 20 minutes whole blood clotting time routinely in your ICU? We do. I don't know what is the other.
And everyone does it. I think all ICUs now follow it. It's the simplest step possible. And I think everyone does it now.
So if what is the maximum poison any snake can actually inject?
5 mg to 150 mg, sir.
So what is the neutralization of each unit of your anti-snake venom?
1
So 1
ml
ml of anti-snake venom will neutralize 0.6
0.6
mg of cobra venom and Russell Viper venom, sir. And 1 ml of anti-snake venom will neutralize about 0.45 mg of
So
Saskel
what is the amount of anti-snake venom you need for 150 mg?
10 vials, sir.
10 vials?
vials.
Overall 20 to 30 vials.
30 vials, sir.
No, that's I think I'm asking about a maximum.
Yes.
You're talking about 150 mg.
So 1 ml will neutralize 0.6 mg,
0.6.
sir.
Hmm.
So 10 vials will neutralize 6
6
mg.
mg.
So 30 vials will neutralize 180 mg, sir, almost.
That's where we are actually somewhere coming about average of that anti-snake venom and around
Yes, sir.
25 to 30 vial maximum. So, but I think we all, Rajiv sir, and we saw some of the situations where we exceeded that.
Yeah.
When it is required, and your whole blood clotting time still remain to be wider in them.
I think most of the questions been answered, sir.
Yeah.
Probably which actually Dr. Maneendra was very focusedly asking the initial part. What is the statistics of when you have a bite? What are the chances that you have a poisonous snake bite and a non-poisonous snake bite?
50% chance of poisonous bite was there, sir.
50%.
50-50, is that?
70% of non-venomous and 30% of venomous bite.
No, it's even more than that.
Okay, sir.
Out of, it's more or less 90% snakes are non-venomous.
If at all you have
But
a
that-
venomous snake bite, how much of them actually have a venom injected to the person, and how many of them are not having any venom injected?
30%.
So we see dry bites.
Nice.
That's what we call it, dry bites, right? So that means what actually Maneendra was trying to find out, a reassurance, somebody helping them, calming down around, you will be all right, will also help many of your patients. And that's how your all local magics help. Like COVID, every drug was working, right? So in a local, everybody is a doctor for the snake bite. They use different methods. The reason for that is dry bites, non-poisonous snake bites. So 80% will do well. When somebody gets a systemic envenomation signs with local and systemic, they will refer to a doctor. To you, to Maneendra, to Rajiv sir, to manage those cases.
The question is, last question I think we should take up on that actually sums up a good discussion. If a patient comes with a doubtful snake bite and apprehensive and asking to give ASB, should we give or should we wait?
Should be
Wait,
wait,
sir.
sir.
Okay, why do you want to wait?
Because anxiety.
Anxiety is fine. Everyone will anxiety. If
Yeah.
a poisonous, non-poisonous, everyone will be anxious. I'll be anxious when I'm bitten. So he's asking for giving a snake ASB.
No, sir, without any.
You are the only doctor. Yeah.
Without any
So what will you tell?
abnormalities or any paralytic, any neurological symptoms, we don't give, sir.
So what will you tell the patient? You have to reassure. No, the whole question starting from the reassurance. How will you tell the patient and the family? No, we don't want to give snake this ASB. And why you want? No. They will ask you, sir, why you are not giving?
Because we will counsel them regarding that there are no systemic manifestations or local progression of the bites, sir. So we can wait. If at all there is any further development of any coagulation abnormalities or neuromuscular involvement or any of the local envenomation which progresses, in such conditions we will proceed with giving anti-snake venom, sir.
In around 70 to 80% of snake bite, most
they
are
are
there
only,
dry bites or non-venomous
non-venomous
snakes.
bite. So
Okay. First thing you will say, a significant portion is non-venomous.
yes, sir.
Second is, now he says, sir, I don't money. How much money you take, but you give the ASV. He's forcing you to give ASV now.
We'll
You don't
explain
want to talk about
the risks of
anaphylaxis?
anti-snake venom, sir.
Hmm?
We will explain the risks of anti-snake venom, sir.
Hmm.
Comparing to benefits, there is a risk without any clinical manifestations.
Okay. First, you have to
Okay.
tell them there's no prophylactic dose.
Okay.
Prophylactic dose do not work. Only it works if there is evidence of envenomation.
Okay.
It is not prophylactically any cannot be given. Second is the risk of anaphylaxis and even a cardiac arrest and ventilation post ASV should be highlighted. Very clearly highlighted that it is not a drug just like any other medicine we have to give. There is a real risk of anaphylaxis, and the patient could actually die or could go on a ventilator and have complications just because of your treatment. That will many times deter many people, attendants and patients. Okay, and from the medical side, why do you want to wait? Patient is asking, let me give it. I know I can have adrenaline. I know I will give it slowly. As a doctor, why wait? Patient, why bother? Patient is asking, let me give it. I have my staff is very good in managing allergic reactions. Let me give it. Why take the botheration? He's calling me continuously. What is the social responsibility? It is a scarce.
Yes.
It is not easily available. As a from the doctor's point of view, it is a scarce. It is not easily available, and we need to preserve it for really deserving people. That's why that is our social and medical responsibility to preserve anti-snake venom. That's why also we will not try to initiate unless there is absolute indication. So that's your social responsibility. Along with counseling to the patient, your responsibility also is important.
Duration for which you will observe for local and systemic envenomation signs?
Yeah.
Local.
We will wait for 24 to 48 hours. So,
Simple question. The patient wants to go home now.
mm.
6 hours in emergency is absolutely fine. He had a good sip
We
of
will
drink,
observe for-
juice. He had a juice, good juice. He feels fine. I'm happy, relaxed. 6 hours over, no symptoms, absolutely fine.
We will
He
observe
wants to
at
go.
least 24 hours, sir.
24 hours.
What is the maximum time any envenomation which can present to a life-threatening illness from a asymptomatic state? And which is that category of snake bite which can present that?
In a delayed presentation, most common is crate bite, sir.
What is the
Up to
maximum
36
duration?
hours.
36 hours.
36 hours.
It will present.
Presence.
So something like that. So if something can happen, if somebody wants to go also, you need to explain that with current medical legal constraints. That is where you have to actually put your notes on key. You need to be observed for that period. And there is another interesting part happens, as Rajiv sir said, a snake bite comes in a local primary center, they get an ASV, sir, and they come to your center. For the first 24-48 hours, you have given an ASV, you will have no symptoms at all. Because there was a ASV dose given, and he says the bite is there or not there, and you also reassuring there is nothing. But you may develop after 24-48 hours the symptoms because there was one neutralizing dose given at that time. And after 20-48 hours, you'll see. Sir, few more questions are there, sir. We'll take them and probably conclude.
I don't see
Same
any major
question answer
question.
session. You want me to read, sir?
One
Question answer
I think
session,
not-
there are 2 questions.
I don't think major questions we have already
The
answered.
questions are not there, sir.
Should-
But
Patient
not
with
waste-
hematuria, there is some doubt. Hematuria
said,
after ASV, should we complete dose of ASV or proceed with FFP?
We will complete dose with ASV, sir.
Yes.
So it is not with the ASV as a complication. I think probably this patient had gone into a extracellular necrosis or renal shutdown.
Should the patient need to get the snake along with him? If it is live, please don't get it.
No, sir.
So it is a very what you say local practice that whenever there is a snake bite happens, they try to kill the snake and get the snake in a cover in a rural areas, which is strongly recommended not to be done. Maximum you can probably take a snap of it and get it, not the snake, which can harm more.
I think we can conclude now.
Yeah, yeah.
Venkat.
Sir, the last question I think you can take, sir, and conclude that basic protocols in evaluation in summary. Rajiv, sir.
Where is the question? Basic?
And what are the flow
Overall,
protocols when a snake bite patient comes to you in a
Okay. So I think, yeah, most of the things which we have answered, the most important thing which we need to understand is all venomous snakes are not venomous. Most of the snakes in India are non-venomous. So any patient just presents with snake venom, snake bite suspected or proven, should, as we discussed, should watch for evidence of envenomation before we initiate any anti-snake venom treatment. Reassurance is the most important thing. Patients can have cardiac arrest immediately post snake bite because of vasovagal syndrome, could be having a underlying cardiomyopathy, which can get caused tachycardia and sudden cardiac arrest because of extreme anxiety or extreme sympathetic overactivity. So that those things are possible, but that is not related to the snake bite directly. That's just because of the hypersympathetic response that would happen in some people. Watch for envenomation, look for signs of envenomation, look for the bite marks, which may sometimes help you in identifying what type of bite it is. And as we discussed, envenomation, two types. Basically, we're looking at vasculotoxic and neurotoxic. Neurotoxic, again, we divide it into crates and vipers. Vasculotoxic, basically, it's the dose of ASV is little more than what we give in neurotoxic, mainly because in neurotoxic, it is a bound toxin which cannot be neutralized by giving ASV. So no point in continuously giving ASV just to neutralize the toxin, is already bound. Better than that, early intubation. Use of neostigmine can be used as a diagnostic tool in some cases. Sometimes for transport of patients where ventilation facilities or the doctor is not able to intubate the patient. As a transport facility, transport method, we can be used neostigmine with a combination with atropine to transport the patient to the ventilation area for intubation. Dose of snake bite, again, we discussed upper limits, mostly average around 20 vials for a neurotoxic bite and up to 30 vials for a vasculotoxic bite. First dose is 10 vials initially, followed by 5 vials. Best easiest monitoring tool being the whole blood clotting time, can be done by any resident registrar at the bedside with a simple glass tube and keeping the glass tube with a 5 ml of blood and keeping it standing for 20 minutes and watching for the coagulation, whether blood clotted or not. Initially, before giving ASV, WBC should be done every 30 minutes for the first 2 to 3 hours, then every hour for 6 hours. In 6 hours, if you don't see any evidence of WBCT worsening, then probably there's no coagulopathy, but still you need to monitor the patient. Once you have given ASV, the WBCT takes a backseat. It becomes more of a PT INR monitoring, which is done every 6 hours. And repeat doses can be given based on the PT INR and the evidence of coagulopathy. If the patient is going for evidence of compartment syndrome in a vasculotoxic snake bite, calling the surgeon to do a debridement or a fasciotomy will be indicated. And in some cases, such cases may be followed by a 5 vials of ASV subsequent to the fasciotomy. If there is a tourniquet applied to come from outside, if possible, the pressure BP cuff to be put proximal to the tourniquet and progressively released. The tourniquet released with the BP cuff slowly, progressively released. After this, envenomation and reaction to snake antivenom is very significant possible, and many patients do develop it. But fortunately, most of the ones are mild and which can be easily managed with antihistamines. So mild reactions mostly managed with antihistamines without interruption in the doses. And severe reactions like anaphylaxis, the dosage is stopped for some time. Patient is basically given adrenaline and blood pressure restored, stabilized, and then reinstitution of the ASV at a diluted concentration and also with a lower flow rates. There's no role of correction of PT INR just because of we need to correct the number. It's all based on the patients having active bleeding or a high risk of bleeding, especially in patients already on anticoagulants and multiple antiplatelets. because it is a tool. Not only, I mean, there's no guideline. The correction will help the patient. Second, it is a tool to know the coagulopathy worsening or improving. So unless the patient is actively bleeding, we would not control or correct giving FFP or cryos. And lastly, what our whole trial is to see that we preserve ASV, not rampantly keep on giving ASV because it's scarce resource. Whenever possible, observe the patient in your center as closely as possible. And only when signs of envenomation start ASV, reassure the patient and tell them the risk of giving ASV and also the medical fraternity as saving ASV for other really deserving patients.
Thank you, sir.
Thank you, Raju sir, for that elaborative. Maneendra, a very specific question to you. Both of them are exam going students, and many exam going students are listening to both of you as an examiners. What is that you wanted to actually tell to the students? These are the 20-30 points which are very important if suppose you get a envenomation as a long case.
20-30 points.
I think all
Exam points
think I-
questions at least. Exam
Rajiv sir elaborated almost everything from the how they should be mobilized from the place of bite to the hospital. We have discussed everything, sir. So
first aid, ASB indication, something like that.
Yeah,
The-
that also, I think the questions also should be ready for basically how the patient should be managed in the outside the hospital, at the site of envenomation, how the patient to be transported also should be asked, along with subsequent treatment, which we all discussed, the number of points that I discussed, all these things. So have to, and also when we talk of snake bite, many cases will actually come with the complications. So as a student, like we're discussing of acute kidney injury, like we're discussing about what you call as rhabdomyolysis. So these things also will be an extension of your snake bite. So you will be asked questions on rhabdomyolysis, coagulopathy, rhabdomyolysis, your TEG that we're discussing now. So those things also will come. Snake envenomation will lead to those questions. Even in some cases, acute respiratory distress syndrome also will be part of this. So that also may come in your discussion in such cases.
So organ system failures can be asked to them and their mechanism in each area.
Correct.
And supporting system, probably renal wise, respiratory wise, neuromuscular blockade wise, those all can be questions. And some of them, as they ask also, how do you paralyze them? How do you sedate them? How do you assist them? Those can be a question. And renal replacement therapy indication, how do proceed about this can also. Coagulation, as we all discussed, I think Maneendra pointed out from whole blood clotting time to basic coagulation parameter to TEG also. These patients also land up in sicker group in DIC, where they actually can lead to death. That is the end point of many of these coagulopathic patients who is actually lose their life when they present to us in late stage when multiple organs are injured and they land. So in those situations, maybe TEG will be helpful. You don't know what to give, what not to give, as Maneendra pointed out. I think these are the spectrum of errors which can arise. Anything to add, Maneendra? I think I wanted Maneendra to add at the end.
I think you with two good speakers and short of words.
We wanted every facet of it. We have Maneendra's facet, we have Rajib Paul sir facet. So we will see what happens in exam. That's what I every time talk to my student. You may be going through your learning from one set of examiners in your center. There will be a completely different angle, different viewpoint from another set of examiners who take your exam in another center. So when we listen to the multiple examiners, even though standard of care remains same, but I think the way they wanted to know the answer from you, somebody expects some answer, somebody expects a different way of answering. So that is what they are learning from all of you. That's, I think, is the beauty of when we students present and different examiners take exam. What do you say, Maneendra?
I think apart from autonomic instability, we discussed everything else. Autonomic instability is one thing which we did not discuss. So snake bites can present with autonomic instability. A patient can present with something like a tachybrady. Suddenly there will be a brady, then a tachy, which we frequently see in GBS.
Yes. more in GBS. And,
So autonomic instability is one thing which we did not discuss.
and
apart from that,
cardiotoxicity, shock also is not uncommon. We see some of them when multiple organ failures, they'll end up in refractory hypotension. This is not also uncommon. What is your experience, Maneendra, in these cases? Also, we see some of those cases who present to us in late, they'll end up in myocardial depression, shock. You may say is a stress cardiomyopathy. You may say is a catecholaminergia. So this is not also uncommon in them. Okay, over to you, Kaladhar. I think we had an interesting session today.
Yes, sir. Yeah, very interesting session. I think most of the participants, they actually was are asking questions and giving responses, sir. So almost very engaging discussion happened. So I thank Dr. Rajib Paul sir and Dr. Maneendra and Dr. Venkat sir for giving all the insights and your experience. I think most of them got benefited. Overall summary was also given very nicely by Rajib sir. And thank you, Dr. Vyshnavi and Dr. Vinay for bringing out this case for a nice discussion. And thank you all. Thank you, our digital team and branding and Yashoda Hospitals for providing this platform for regularly discussing these cases and I think knowledge spreading.
Thank you, Rajiv sir and Maneendra
Thank you.
for being here.
thank you, sir. Thank you, sir.
Thank you,
Thank you,
Venkat.
sir.
Thank you very
Thank
much.
you.
Bye. Bye.